So the lecture number 2 of diabetes series. In previous lecture, we discussed about the diagnosis of diabetes mellitus. The diagnosis of diabetes mellitus is relatively straightforward. In asymptomatic individual, if 2 out of 3 tests are positive, or in symptomatic individual, any patient who have typical symptoms of diabetes and one of the tests is positive, then the diagnosis of diabetes mellitus is established. But the most crucial step in the management of diabetes is to categorize diabetic patient into specific subtype of diabetes. To diagnose specific type of diabetes mellitus is extremely important in proper management of diabetes. The traditional understanding that type 1 diabetes only occur during younger child group or during early period of life, and that type 2 diabetic patient only occur after 35 years of age is completely wrong. It has become obsolete because type 1 diabetic patient can occur at any age, even in elderly. Similarly, type 2 diabetes is becoming more and more common in relatively younger age group because of the rising epidemic of obesity in children, in younger individuals. So that's why it's very important to correctly identify specific type of diabetes in diabetic patient, in newly diagnosed diabetic patients. Remember that more than 45% of the adult patient with type 1 diabetes is wrongly diagnosed as type 2 diabetes. And similarly, most of the children who are suffering from type 2 diabetes are wrongly labeled as type 1 diabetes. And they have serious consequences because each type of diabetes vary in its clinical presentation, the response to various anti-diabetic medications, and the risk and progression of complication also vary in subtype of diabetes. For example, if the adult patient with type 1 diabetes is misdiagnosed as type 2 diabetes, and these patients are started on oral anti-diabetic medications, so they will not respond to any intervention except insulin, and the risk of complications and the blood glucose level control will be poor, and the risk of complication will be higher in such individuals. Similarly, if during early life, if the type 2 diabetic patient is misdiagnosed as type 1 diabetes and started on insulin, the anxiety and the psychological and mental trauma of diagnosing or labeling patient as type 1 diabetes and the initiation of insulin in such patient is extremely psychologically very traumatic to the patient, to the caregiver. So very important to establishing the correct diagnosis of diabetes to identify specific type of diabetes. So in this lecture, the main objective of today's lecture is to differentiate between type 1, type 2 diabetes and a specific type of inherited diabetes, that is maturity onset diabetes of young. To know about different type of autoantibodies involved in type 1 diabetes. What is C-peptide? Its role in differentiating between type 1, type 2 diabetes and MODY. These are the 5 category of specific type of diabetes. The diagnosis of gestational diabetes is only occur during gestation and in the second and third trimester of pregnancy. And the secondary diabetes is usually easy to pick because of the clinical manifestation of the primary disease. For example, Cushing syndrome, the typical facial plethora and other clinical manifestation of Cushing syndrome, the acromegaly and pheochromocytoma, there would be clinical features of the primary disease, the history of pancreatitis, the history of exposure to high risk medication, glucocorticoid. But the main confusion arises between type 1 diabetes, which is an absolute insulin deficiency due to pancreatic beta cell destruction, type 2 diabetes because of insulin resistance, and maturity onset diabetes of young. Because maturity onset diabetes of young is very much alike to type 1 diabetes because it occurs at relatively younger age group, less than 25 years of age, at relatively no normal or even lower BMI. So that's why sometimes MODY is confused with the type 1 diabetes, and the patient is wrongly started on insulin. So these are the three important subtype of diabetes that required consideration whenever a newly diagnosed patient is presented with diabetes. And so as a general rule, type 1 diabetic patient more common in children and younger age group. The BMI is relatively normal. The cutoff value for Asian is lower compared to non-Asian because we Asians are prone to develop central adiposity, central obesity, and more accumulation of fat in our viscera that predisposes to develop type 2 diabetes and metabolic syndrome. So that's why our cutoff value for BMI is lower compared to non-Asian. So if the BMI is less than 23 in Asian and in non-Asian less than 25, classical symptoms of polyuria, polydipsia, and unexplained weight loss. These are the symptoms tried that are characteristically present in type 1 diabetic patient and that occur acutely within weeks. So these are the three important symptoms that manifest in a type 1 diabetic patient. Half of type 1 diabetes presented with diabetic ketoacidosis. In one study, more than 85% of the type 1 diabetic patients are diagnosed with clinical presentation of diabetic ketoacidosis. And type 1 diabetic patients presented with very high blood glucose level more than 360 milligram per deciliter. Remember that type 1 diabetes may occur at any age, even in elderly, but the onset at later age is not dramatic. It's not with the classical symptoms of type 1 diabetes such as polyuria, polydipsia, and unexplained weight loss, and rarely present with decay at initial diagnosis. And they do well. In the initial 6 months of their diagnosis with oral anti-diabetic medications without insulin. So the best predictors of type 1 diabetes, symptoms tried, polyuria, polydipsia, and unexplained weight loss, which presented with acutely. The age of the patient less than 35 years. Remember that this is the peak incidence of type 1 diabetic patient in 15 to 30 years of age, moderately high, and beyond 30 years, the risk of type 1 diabetes decline. Commonly occur in lean thin patient, lower BMI patient, and the presence of other autoimmune diseases such as autoimmune thyroid disease, celiac disease, vitiligo, Addison disease. Um, in the presence of other autoimmune disease, the probability of type 1 diabetic patient, because it's an autoimmune disease, will be very high. Type 2 diabetes more common in adult more than 35 years of age. It is because of insulin resistance, and there will be insulin resistant features present. Obesity, acanthosis nigricans, metabolic dysfunction associated steatotic liver disease. The BMI is higher, more than 23 in Asian and more than 25 in non-Asian. And absence of type 1 diabetic features such as the symptom triads, polyuria, polydipsia, absence of there will be absence of weight loss, absence of diabetic ketoacidosis, and less marked hyperglycemia. Blood glucose level usually at presentation is not more than 350, 360, which commonly found in type 1 diabetic patient. Strong family history of type 2 diabetes, but the absence of family history of type 1 diabetes. So the best predictor of type 2 diabetes is age of onset greater than 35 years, higher BMI and features of insulin resistance, and family history of type 2 diabetes, and the lack of characteristic features of type 1 diabetes such as symptoms triad, autoimmune diseases, absence of autoimmune antibodies. Majority onset diabetes of young is an inherited form of diabetes. It has an autosomal dominant inheritance. It's a single gene defect. There are 14 subtypes of MODY, each vary in its clinical presentation. Some are super sensitive to sulfonylurea. One of the subtype, glucokinase MODY, do not require treatment. Very important point to remember that adequate C-peptide level. C-peptide is a marker of beta cell reserve or beta cell function, and there is adequate beta C-peptide level in MODY patient in contrast to type 1 diabetic patient in whom the C-peptide level is very, very low. The absence of islet antibodies, because this is the important differentiating point between type 1 diabetes and MODY. There is a MODY probability calculated to identify high risk or highly suspected MODY individual in whom genetic testing should be done. Because genetic testing is not widely available and is quite expensive, then high probability patients should be subjected for genetic testing to correctly identify subtype of MODY. So, similar to type 1 diabetic patient, the MODY patient has a lower BMI or normal BMI, less than 23 in Asian, less than 25 non-Asian, age of an onset less than 25, strong family history of diabetes. The autosomal dominant inheritance, every generation has diabetic patient, grandparents, parents, or and siblings, all are suffering from diabetes. And the inheritance is vertical transmission. If one of the parent is suffering from diabetes, then half of the children are affected by MODY or diabetes. Absence of autoimmune diseases and non-diabetic organ manifestation. The presence of certain organ manifestation, the congenital defect, commonly as renal cyst, genitourinary malformation, and congenital renal defects. If these are present, then the probability of MODY is very, very high. So, the diagnosis of type 1 diabetes in younger age group, if the age is less than 20 years, particularly less than 15 years, with the acute presentation of polyuria, polydipsia, weight loss, or diabetic ketoacidosis, do not require any investigations, or patient should be started on insulin straight away. But if the onset of diabetes is in late 30s, after 40 years of age, then this algorithm should be followed. So you suspect type 1 diabetes whenever patient presented with atypical features. For example, the unexplained weight loss, very high blood glucose level, the absence of insulin resistance features such as acanthosis nigricans, obesity, fatty liver, all of these. So the first test you have to check or you have to do is anti-islet autoantibodies. So we will discuss in the next slide what are the islet antibodies. So if these antibodies are positive, then the diagnosis of type 1 diabetes is established and the patient should be started on insulin. There is no further testing required. But if antibodies are negative, remember 5 to 10% of the patient with adult onset of type 1 diabetes are antibodies negative. Then you assess the age. If the age is less than 35 years, you look for the features of MODY, such as the low normal BMI, the age less than 25, the non-diabetic organ manifestation, the family history of diabetes that are running in generations. So if features of MODY are present, then you check the C-peptide level. So if the C-peptide level is more than 200 picomole per liter, then patient should have genetic testing for MODY. But if the C-peptide level is less than 200 picomole per liter, suggesting poor beta cell reserve, the poor capacity of pancreas to produce insulin, then the diagnosis is type 1 diabetes and the patient should be managed with insulin. If the features of MODY are absent, then you assess the features of type 2 diabetes. That was metabolic syndrome features, acanthosis nigricans, obesity, fatty liver, the blood glucose level is not very high, the HbA1c is not very high. So if the features of type 2 diabetes are absent, then the patient should be managed as type 1 diabetes. But if the age of the patient is more than 35 years in the absence of autoantibodies, and if the features of type 2 diabetes are present, then the patient should be labeled as type 2 diabetes and should be managed with oral anti-diabetic medication along with lifestyle modifications. So this is a very important algorithm to remember that, and the two important tests that are required in diabetic patients are islet autoantibodies and C-peptide level. These are the two important tests in differentiating between type 1 diabetes, type 2 diabetes, and maturity onset diabetes of young. So autoantibodies in type 1 diabetes, these are the four autoantibodies that could be present in type 1 diabetic patient. Anti-gate 65 antibody, anti-islet antigen 2 antibody, anti-insulin antibody in insulin naive patient, and anti-zinc transport 8 antibody. Remember that anti-GATE65 is the most sensitive antibody in autoimmune diabetes. These are usually asked in exams, so it's very important to remember that the most sensitive antibody is anti-GATE65, and anti-islet antigen 2 antibody is the specific antibody and associated with rapid progression. First to appear in children, less common in adult onset type 1 diabetes. In adult, anti-GATE65 is more commonly present, and it has high specificity. Anti-zinc transport 8 antibody, useful marker in antibody negative cases. If all of the three antibodies are negative, then zinc transport 8 antibody should be checked to identify autoimmune type 1 diabetes. C-peptide level, remember that insulin is produced in the form of proinsulin, and when beta cells secrete insulin, the proinsulin is break down into insulin and C-peptide level, and the production of insulin and C-peptide level is in equal amount. To assess the beta cell reserve or the pancreas capacity to produce insulin, we usually do not check serum insulin level. We usually assess the C-peptide level. And why? Serum insulin is an unreliable marker of beta cell function due to following reason. The serum insulin affected by exogenous insulin. If somebody is on insulin, then the blood insulin or the serum insulin level will not reflect the true level of the patient, as level cannot distinguish between body insulin from exogenous insulin. Liver metabolism, 50 to 80% of the insulin extracted before reaching to systemic circulation. That's why it's not a true reflection of beta cell function, because majority of the insulin that are produced by the pancreas are extracted by liver. Very short half-life, so not stable in the serum, just 3 to 5 minutes, and cannot be used if patient is on insulin therapy. So these are the important different points from exam point of view. It's very important to remember that if you want to assess the function of beta cell, you have to check the C-peptide level. And insulin is a very poor marker of beta cell function, so it has no role in assessing the pancreatic beta cell reserve. So C-peptide origin from endogenous beta cell only, and insulin could be endogenous or exogenous. C-peptide liver metabolism is minimal, and insulin liver metabolism is extensive. C-peptide half-life is 30 minutes, so it's more stable in the serum, while insulin has a very short half-life, 1 to 3 minutes. Impact of insulin injection, C-peptide level unaffected, insulin directly measure cannot distinguish. C-peptide utility in treated patient, in insulin treated patient, perfectly usable, while insulin useless, reflect injection dose timing, not beta cell function. So this is very, very important to remember that. C-peptide level, so random level within 5 hours of eating with concurrent blood glucose level. Why? Because if the blood glucose level is less than 70 milligram per deciliter, then the C-peptide level will be falsely low. Because if blood glucose level is low, no more insulin is required. So the production of insulin will be impaired if blood glucose level is low. If C-peptide level is less than 200 picomole per liter in the absence of hypoglycemia, then the patient is suffering from severe insulin deficiency. Between 200 to 600 picomole per liter, it's a gray zone. And if it is more than 600 picomole per liter, adequate beta cell function, suggesting there are adequate beta cell available for production of insulin. If C-peptide level is 600 or above, or less than 80 picomole per liter, circumstances do not matter. The blood glucose level do not affect it in such higher value of C-peptide level or such lower value of C-peptide level. If the C-peptide level is 600 or below and the concurrent blood glucose is less than 70 or patient in fasting, they need to be repeated, because as I've suggested that in the presence of lower blood glucose level, C-peptide will be falsely low. C-peptide measurement before insulin discontinuation to exclude severe insulin deficiency, because if you discontinue insulin before checking C-peptide level and the patient is severely insulin deficient, then the risk of diabetic ketoacidosis will be very high in such individual. Therefore, C-peptide must be measured before insulin discontinuation to exclude severe insulin deficiency. Never check C-peptide level within 2 weeks of hyperglycemic emergency, because glucotoxicity transiently shut down the beta cell function and the C-peptide level would be falsely low in such circumstances. So after recovery of hyperglycemia, 2 weeks of recovery of hyperglycemic emergency, C-peptide level should be assessed. So in summary, the antibodies are very important in identification of autoimmune type 1 diabetic patients, and these are the four anti-islet autoantibodies that are positive in autoimmune type 1 diabetic patients. So anti-islet cell antibodies, marker of beta cell autoimmunity, anti-GAD antibody most sensitive, anti-islet antigen 2 antibody most specific and suggests rapid progression, anti-insulin antibody should be checked in insulin naive patient, and anti-zinc transport 8 antibody may be useful in antibody negative patient. If the three of the antibodies are negative, then anti-zinc transport 8 antibody should be assessed. C-peptide level useful marker of beta cell function. Serum insulin, very poor marker of beta cell function and should not be checked to assess the beta cell function. 5 to 10% of type 1 diabetic patients, especially in adulthood, are antibodies negative, and if C-peptide level is less than 200 picomole per liter, such patients should be treated with insulin. Very, very important to remember. So in the next lecture, I will discuss the type 1 diabetes pathogenesis, prediction, and clinical staging. Thank you so much for your listening.